The next life-threatening condition concerning with with breathing, with chest is massive hemothorax. When you should think about diagnosing massive hemothorax, when you would see a lot of blood going out from the tracheostomy or going out through the drain. If it's around 1.5 liter at once after putting the drain, for sure the patient needs tracheotomy. Because it's bleeding from the chest, from the pleural cavity. If bleeding, let's say, is not so huge but continues to exist during the first 4 hours, and you've got, let's say, at least 1 liter after 4 hours, you should also think about diagnosing massive hemothorax. And what's the main reason of the bleeding into the pleural cavity? So usually it's due to multiple fractures of the ribs and the rupture of the intercostal arteries that bleed into the pleural cavity. And also it might be provoked by the injury and bleeding from the internal thoracic artery. So what's the pathophysiology? We've got two problems. We've got hypoxia because the lung is compressed by the blood which accumulates in the pleural cavity, and the second problem is hypovolemia due to hemorrhagic shock due to loss of blood. So hypoxia and hypovolemia, the main things, the main problems in the massive hemothorax. And what are the symptoms? So of course the chest trauma, on palpation some crepitus of the broken ribs. On percussion you would have the dull sound. You might have the surgical emphysema also. So dull sound. The next thing, on auscultation you might hear nothing or diminished breath sounds. So if you've got those two things and the patient is in the hemorrhagic shock, is in shock, you should think about massive hemothorax. When it comes to respiratory failure, it's let's say usually due to hypovolemic shock, then rather than due to hematoma pressing against the lung tissue. So generally the patient would present with hemorrhagic shock mainly or at the beginning. So that's the main problem. And for the quick diagnosis of the hematoma in the pleural cavity, the ultrasound and EFAS protocol is a gold standard, and it's quick, and it's you can repeat it, and it's fast as its name. So the ultrasound in massive hemothorax, in tension pneumothorax really helps. What's the treatment? So actually, let's say the basic treatment of the respiratory failure would be mechanical ventilation, so securing the airways and putting the patient on the ventilator. So that's the one thing. The treatment of the hemorrhagic shock would be giving fluids, and in the hospital giving the blood products. And in case of severe decompensating hemorrhagic shock, when you diagnose the massive hemothorax and it's, let's say, isolated, it's recommended to pre-fill patients with fluids or blood products before, let's say, putting the drain, to prevent the sudden drop of the blood pressure after insertion of the chest drain and emptying the pleural cavity. So be aware of it, give fluids, give blood products, and then put a drain to the chest cavity. You can see here where the drain is inserted. Next problem is circumferential chest burn. So we can see here the patient with the full thickness, 3rd degree burns of the chest, and you can see also the incision, the escharotomy performed on the chest of this patient. So the main problem in such circumferential chest burns is that due to the full thickness burn and eschar that develops, the compliance of the lungs decreases, and the eschar prevents the chest expansion and air entry. So actually, we cannot effectively ventilate the patient because the chest cage is not moving. The chest is not moving, it's not expanding, because it's restricted by the eschar due to third-degree burns. So the respiration and ventilation may be compromised. The patient, usually such patients are quite quickly intubated and ventilated, so you would see on the respirator the alarm that there is high pressure of ventilation, and you should react in such situations. So generally reaction is escharotomy, so incision of the burns in anatomical lines, as you can see on the picture. And the last thing that we will talk in the life-threatening conditions in trauma patients connected with breathing would be the spinal cord injury and the side effects of the spinal cord injury in respiratory system. So what we might have in such patients, if there is the level injury of the spinal cord is high, like C1 to C3, we would have patient with apnea and respiratory arrest because there is total paralysis of diaphragm and intercostal muscles. So the patient cannot breathe because his chest cannot move due to spinal cord injury. In C3, C5, we might have problems with diaphragm working properly. So there might be deterioration of the diaphragm function. So also it might lead to apnea, respiratory arrest. Actually, the patients have the chance to breathe by themselves when the spinal cord injury is below C5, because the diaphragm is working, so the patient is breathing thanks to diaphragm, but the intercostal muscles are not working, so we would see among those patients the diaphragmatic breathing. So the therapy of the patient with the spinal cord injury who has problems with breathing, with tachypnea, small tidal volume, and diaphragmatic breathing, actually to prevent respiratory failure, quite quick securing of the airways and mechanical ventilation.